we're live, episode 3. We got, I was going to say Miss, but I'm going to say Dr. Amy De La Torre.
Yeah.
And in many aspects and many regards, it feels like a homecoming.
It does. Yeah.
And you've spent more time with Amy than I have, at least from the very beginning. And Amy has seen us and worked with us all the way till the beginning of Chicago EMT training.
Mm-hmm.
And then she had to go do her doctor things. And I'm interested to hear all about it, all the decisions that you made, your experiences through maybe even back to somewhat of IMSA, but then like GPPA, the ambulance times with Marty. So welcome. Well, it's so good to see you.
It's good to be back.
Welcome back. Yeah.
Yeah.
Well, welcome to this. I don't know if this is back. We're moving in the future. Who knows? Yeah.
What do you mean? Well, welcome to Chicago.
This iteration.
Yeah.
Yeah.
We're always evolving.
Yeah. Oh, I know. You guys are always on something new and different, and that's why I love coming here. It's like always different. It's always set up different. There's always something new going on.
Yeah, it keeps it interesting.
That's Victor.
Yeah.
I'm the traditionalist. Victor's the dreamer. So Amy, you're an OG. You were from the early UIC days. I think you probably got started in the class, if I had to remember, maybe like 2014-ish, 15-ish.
Yeah.
You were in the same class with like Ram. And,
I was.
Oh, okay.
Yeah.
Did you take the class at EHSO or were we? Yeah, because we had, so Rich Anderson was still there because he let us use the classroom at EHSO.
Did you have a hard time getting lecture space? Is that why? Or
yeah, I think it was a combination of that and just convenience.
Sure.
But yeah, I mean, he's like, because they didn't have that space built when we first started. And he's like, we have this huge space, so let's use it. Which was nice. I mean, it was small.
Yeah.
It could really only accommodate maybe 25-ish students, but.
So, Amy, what was your first, not even experience, but when did you first hear about the program or becoming an EMT? I'm curious as to how much of your inherent motivation for medicine and healthcare came from within, or how much of it was molded from outside people, family, IMSA. Where did that all come from?
Yeah, I guess the first time I heard about to start with the EMS program with UIC EMT, it was through a summer program. So I actually wasn't even a student at UIC yet, but having come from IMSA or the Illinois Math and Science Academy, they start you young and expose you to a lot of good opportunities. And one of those opportunities was the summer Latino, I forget what it was called. It was called LASEP at the time.
Okay.
But basically it was a summer program for underrepresented minorities coming into UIC as freshmen. And they had someone kind of mention it. They're like, oh, and UIC has lots of different pre-med programs. There's an EMT program. You can become an EMT. You can get trained here. And I was like, whoa, that sounds.
So they knew about that and all the way to IMSA? Are you surprised by this?
I kind of am. I mean, I felt like the constant burden of we need to tell people
no one knew
this. Yeah. Because there was no network externality. Nobody knew about it. So that is pretty surprising.
Yeah, I think the way it worked was through the Latino, it's called HCOE, or the Hispanic Center of Excellence at UIC, at the university. Yeah. They were aware of your program.
Okay.
And then through that program, they were like, oh, hey, you're pre-med, this is something that would be really cool. It's in the summer, you're here anyway, would you be interested?
You kind of dealt with, not to get into too much of the, the drama of UIC, but I remember that when you worked for housing, we were trying to leverage housing because Victor and I were pretty much told you need to find some way to make this program survive. And that was a constant concern that Victor and I always had. It's up to you to make this thing survive. It's but we don't even own it. How can, and that, and that was kind of for us, kind of the bottom line when we kind of took this on the road. But I remember housing and trying to like leverage housing, and they're like, "Oh, we didn't know there was an EMT program." It's like we've been here 6 or 7 years.
Like pre-pandemic, like
no, there's like during.
Oh, during the pandemic.
Yeah, like at the very beginning or like
I
right
feel like
before.
we had pre-pandemic conversations as far as trying to provide services amongst the dorms.
Yeah.
And then in the pandemic, it was like figuring out a way to house sick individuals.
Yeah.
Yeah.
Or like people who couldn't leave the country. And it was
Yeah.
Wild
crazy.
time. Yeah.
So what do you remember about the EMT class back then?
I remember it was at EHSO. We still had the little bunker upstairs.
Oh,
with
yeah.
The bunk beds.
Did that excite? And you were
did.
still in high school, so
Yeah.
Did you kind of like foreshadowing of like what life could be like at UIC?
Yeah, definitely. It was really exciting. It was like, I took the class my first semester freshman year.
Okay.
So I like went and started doing all the registration stuff like right before school started.
And were you weighing options, or was UIC always it?
It was always it. Yeah. For me, at least, once I found out I got into the GPPA program,
Wow.
I was like, how could you turn down a automatic seat?
Is
in
that
med school?
scary though? Is that to put? And I'm sure you could have backed out any time of like, I don't want to do this anymore. But I know it's hard, very difficult to get into that program and like maintain that status.
Yeah, and even starting from a young age, kind of to go back to Victor's question, like, so when you went to IMSA, so there's like a recruitment process, and they're like, oh, these are going to be like future doctors. When did you know that you wanted to get into medicine?
Yeah.
For being real, like in kindergarten.
Yeah.
Okay.
Like this goes back to like kindergarten.
The
like,
other day,
Yeah.
John and Ruthie yesterday said it was watching ER, but for you, it was back in the day.
back
It's better
in the
than
day.
watching snuff films and like saying, oh, I could save that person.
Yeah, no, it really was.
What
That's, like,
what
it
did you
started.
experience or witness in kindergarten?
It was just, I would always go to like doctor's visits with my family.
Okay.
And obviously like there were no Spanish speaking doctors around my family at that time. And I was one of the few people in the family that
Translator.
did. Yeah. So I was the little translator. So you had a little like barely speaking at all, like translating.
That's kind of cool.
So it was pretty cool. Yeah. And we did have a great doctor at that time.
Okay.
So I would always like, they'd ask you at school, like, oh, what do you want to be when you grow up?
Yeah.
Oh, I'm going to be a doctor. And it was
Yeah.
just so like set in stone for me. And
Okay.
that's what stuck. And my parents were just very supportive of it. So
If we were to
Yeah.
move forward a little bit, like, did you ever waver in that decision?
I have yet to waver in that decision. Yeah.
okay.
I feel like I've always had other thoughts. I'm like, oh, well, like if for some reason I for whatever reason, God forbid, I can't do it.
Yeah.
Like I would love to be a gym teacher.
Oh yeah.
Like I've had those thoughts, but I've never like, I'm not
Run the
gonna do this.
mile.
Yeah.
Drop down and give me 20.
Well, when I came on board, I
cancer.
think and consistently throughout, Amy, and you're probably still this way, is like I don't see it too often, the discipline and the ability to manage your time. You're either going to the gym before or after you teach with us.
Yeah.
And it's something that I don't really see
I walked
too
here
often.
actually from my apartment. It was a 4-mile walk. I was like, I can't work out today, so I'm gonna walk there.
Okay. And did you feel like you have the time to walk?
I made the time,
Oh, I like that.
made the
I like the
time.
reframe. So, what was it like in GPPA? And for those that are listening and don't know what GPPA is, it's not just for a guarantee spot in med school. Is it pre-professional
Yeah.
or healthcare in
Professional.
general?
Yeah.
Okay.
So there's dentistry, there's
Okay.
law, there's
Okay.
nursing. Yeah.
I
pretty
see.
much everything.
And was it rigorous to maintain that status? What was that like?
Yeah, it was definitely not easy. So you're taking your regular like course load in general, and then on top of that, you have additional GPPA classes and curriculum that you had to do. But honestly, I think the hardest part was the GPA requirements and the MCAT scores that you had to achieve in order to maintain that. So you could have gone the whole undergrad career
Yeah.
hitting every mark, and then you take the MCAT and don't get a high enough score and you lose your seat.
I thought you
So-
didn't have to take the MCAT.
You do. Yeah,
Oh,
everyone was
okay.
required to. That was the one requirement. You had to take the MCAT and you had to have a certain minimum passing score in order to be considered.
To keep your seat.
Yeah.
So
That is
would
wild.
you say that like with GPPA, if someone maintained that stat, so let's say student isn't part of GPPA, maintained the same benchmarks that you had to maintain, the same GPA benchmark, the same score on the MCAT, maybe same involvement in extracurriculars, would that person have a good chance of getting into medical school, do you say?
Yeah. And I think that was like the goal and the point. Like, regardless of if you're in GPPA or not, like you should still be equally competitive. So GPPA wanted to ensure that we weren't just like kicking back and saying, oh, we've got a seat so we can relax a little bit. It was like, no, you are still expected to be just as competitive as the next applicant. So
yeah, it was almost like you guys were like a cohort. It was like there was like a degree of support you got throughout the way. And I almost probably like peace of mind.
Yeah.
Because I think that like you're eliminating some unknowns. We worked with GPPA
plenty of times.
Yeah,
Oh, you mean as an entity?
Yeah,
or like because we've had plenty of other students.
Well, we still do. Yeah, but remember we held a few spots for GPPA, and I think that we mentioned you a few times.
Well, Amy's mentioned the program several times, right?
For sure. Yeah.
I wonder. Lost my train of thought, but like how this sentiment of like how cutthroat the competition might get, or was it as that camaraderie? Like, was there a sense of camaraderie, or did it feel like, oh, what you're doing this research? You already got published. How many hours of volunteering do you have? Like all that stuff. What was that feeling like?
Yeah, I think the program, like the GPPA program, helped alleviate that in a sense because we all already had a seat. So there was this sense of, like you mentioned, like we were called cohorts, like we were a group, like we were a team. So a lot of times we did study together, and a lot of those people are still to this day like some of my best friends.
Yeah, that's cool.
So it was really cool. I think there was a sense of support amongst us, like not necessarily like, oh, I'm doing this. Like, hey, like, do you guys want to study for this exam together? Or like, oh, we studied a lot. I made the study guide for this exam. Like, do you want to share? And like, so it was really helpful in that sense. And it was like you mentioned, peace of mind. It was like, okay, like I know I have a seat now. I just have to work really hard to keep it. Yeah. And I think that is a different feeling than fighting for a seat.
Oh, sure.
Yeah.
It's almost like you want to continue it, not to fight for your spot, but to kind of, I don't want to say like prove why like you deserve to be here, but almost like you know where you are and what you have, and kind of, and at least this is what it kind of seems to me, is that you guys are trying to, I mean, you're really trying to be using like a Victor word, holistic. You know, you're trying to be very well-rounded just for the sake of being well-rounded, not because you have to, but you held each other to a high standard. And that wasn't because of competition. It was kind of because of pride.
Yeah.
That's a really cool program. Yeah. And is that something that they offer at like other major institutions, or is that like a U of I specifically?
No, I mean, I know IIT.
There's a few other in the country. Yeah. But we are the only one in the country that is non-binding. So UIC's GPPA program is the only one that allows you to apply out. So you have the freedom to go through the entire program and then apply to other medical schools. And go somewhere else. Whereas everywhere else, you stay there.
We asked this question last time with Wajdi.
Sure.
And, I always kind of like to get people's feel on this, because I think Victor and I have our own opinion on this, being kind of like entrepreneurs and, kind of using our degree. But do you think that as and I'm not referring so much to medical school, but, maybe like pre-med, you just getting your undergrad. Do you feel that doctors are overeducated? Do you feel like there's too many hoops for you guys to jump through? Or do you think it would be...
And when you say educated, do you mean the things you have to do in undergrad?
I mean really too much time. And like, do you think like you compare the United States to pretty much the rest of the world, like let's say like Latin America, like Central America, you are admitted into medical school post high school, and it's 6 years. It's not having to get this undergrad degree, which, I mean, yes, any education learning is always great. But do you think that having gone through the whole thing, that it was something that was necessary, or is it something that you grateful for? What's your opinion on kind of?
It's so funny because Amy did so many more extracurriculars.
I mean, you did tons
on top of the necessary work, right?
and I, and I think you're, you have a good perspective on, the amount of work that you had to put into something. But do you think that it's placed on a pedestal? And I'm not saying that's what I think, but is that, have you ever, have you heard people say that before?
So like specifically, do you feel like it's necessary to get published to like feel qualified to get into med school?
Or just take general eds, like tons of these gen ed classes. Do you think it's worth a medical student to pay, $200,000 to get an undergrad degree just for the chance to maybe get into medical school by, buying a $200,000 lottery ticket that you had to pay for and work for?
Yeah, no, that's exactly what I was going to point out. Me personally, I think that it was like, I'm very grateful for the undergrad time that I had because of the position that I was in. Being in GPPA and having that guaranteed seat made my experience very different. So I was very grateful for that time. And I took advantage of that time to explore different things that I was interested and passionate about. I took sculpture classes. I took ancient history classes.
At UIC or outside of UIC?
At UIC.
Oh, wow.
Yeah, I took history of Brazil class, just things I would have never done if I didn't have that guaranteed seat, because my mind would be in a different place. So that is what I view it as. However, I am also very privileged in that I did not pay for my undergrad. I have very close friends and everyone else, and I never talk about it because everyone else around me has large sums of debt. And so I constantly think about that and think about the fact that you have to pay so much money, like you said, for a lottery ticket, for a chance to maybe get in. And that is so scary. That is I think what drives a lot of my counterparts in being so competitive and having those published papers and having all those accolades, because if you didn't
well, and I mean, not to mention specifics or anything, but the suicide rates amongst people who even get into medical school because they're like, I worked this hard for this. And this is not what I want to do. I mean, inherently, the U.S. education system is broken from preschool all the way up. And, I think that there is totally, you agree, when I minored, so I was pre-med bio, I minored in math just because, I minored in history just because, and, I'll be completely candid. I didn't pay for my education either. My parents did. Their rules was you had to work full time, you had to pay your rent, you had to pay for all your food and whatever, but they paid for my education. So I didn't have to worry about those things. And I love what I learned. But then I look at people who don't have that same privilege, and that every moment in time, every dollar needs, is going
that's
to
interesting.
something.
It's interesting, when the kiddos are that age, if you would do it differently.
Oh, I will.
Because you did work your ass off.
Well, and I mean, I still do. And my parents, instilled in me a very tough work ethic. And, that's something I'm grateful for.
Definitely.
But I mean, with my kids, I have this conversation with my wife, and my wife is a lawyer. She went to law school, and tons of debt. But she is very much a believer in higher and formal education. And I say all the time, I'm like, well, if they want to go to school, yes,
Yeah.
you know, but if they don't want to go to school, no way.
Yeah.
I mean, there, like, you think of so many more valuable things than going to first 2 years of college. All the classes you take are bullshit.
Yeah.
I mean, like, you know, you're
The 100
taking
levels. Yeah.
bio 100. It's the same thing you learn in high school, but a little more detailed.
Yeah.
A complete waste of time, complete waste of 2 years. You know, my big thing is that college is, I don't regret going to college.
No, I don't
mean,
either.
and you know, for my you know, my large career where I do other things, having a master's degree financially benefits me.
Yeah.
But I also think, like, well, if I didn't go to college, I mean, I wouldn't probably have, you know, I wouldn't be doing this. I probably wouldn't have met my wife. You know, my life would be in a completely different place. So I have no regrets when it comes to that. But, you know, like, professionally speaking, if I didn't go to college and I just went to EMT school and paramedic school and the fire academy, and then I had the fire department pay for my degree, I would probably be making more money and maybe not as fulfilling of a life. Again,
Like the individuals you met through college, right? As a vessel.
Well, and just where my life is. I am very happy
Yeah.
of where my life is. But yeah, I think it's complicated because it's a grass is greener on the other side.
It is,
you know,
yeah.
You know.
I think it's an expectation.
So, I mean, another way to frame it, Amy, is like on a day-to-day on what you do,
Yeah.
do you feel like the things you learned in undergrad were completely necessary?
a lot of the things that I learned in undergrad were not
We're wrong.
not necessary by any means. I think, unfortunately, like you said, the system's broken. So it is more so a box to check off,
Yeah.
and a piece of paper, a degree to get in
Absolutely.
the next step. It's really
It's not education, it's a rat race. And I
Yeah.
think that finally when you get into medical school, particularly in your internship years, that's really where you're probably forming into the physician that you're going to
Yeah.
be. And I mean, even in sense of being like paramedic, and one of the reasons I really champion paramedic school is because of the practical nature of the education.
I wonder if that was frustrating for year 1 and year 2 of med school, especially coming from patient care experience background.
It was.
Yeah.
Yeah. I would joke with my colleagues. There was one other individual who was an EMT in California, and he was in a lot of my classes, and we would always joke that we were just so not annoyed, but like frustrated. We were itching to be doing
Yeah.
something clinical,
Yeah.
all the while understanding we needed these like basics. But it was just so strange to go from being front lines
Yeah.
to back into a book
Right.
and like being told like you can't, we're not going into the hospital, you have to be book trained for 2 years, like
Yeah.
everyone holding your hand. And it was like, okay, like I got to the point where I learned better and was just like, okay,
Yeah, learn to walk before you can run type of thing.
yeah. And yeah,
Were you with us all throughout med school? Or did
was.
you take some time off?
I think there were a few months during like block exams where I wouldn't come in, but
Yeah.
for the most part, it was like kind of every other month
Sure.
or so, like coming in.
So although you had a guaranteed spot in med school, like could you let some, like a breath out, like just like take a breath once you began med school, or was it just like still go?
Yeah, it was still go at that point. Yeah, I think undergrad, like I said, I mean, even in undergrad, despite having like the scholarships, my parents couldn't afford to have me like housed here in the summer.
Yeah.
So like I had 2 jobs. I worked for you guys. I worked for campus housing.
Yeah.
I picked up side gigs. I would like
Susan
babysit.
Taggart's.
Yeah. So
What'd you do for campus house? Were you?
I was an RA for at some
Oh,
point.
I didn't think I knew that.
Yeah, but I also for the most part did maintenance. So I was cleaning the dorms. I was like
What?
mopping, vacuuming, resetting the dorms for the summer for the next classes. So I'm actually still like best friends with some of the maintenance guys around the school and like see them all the time. It's really cool because they've known me and they know my path. So like they've seen me like wiping down, the bathrooms and now like working in the hospital. So it's been a journey.
So being a Latina, being, if from your description, I don't really know your history, but like first generation English speaking, you know, from what you are saying and working for the university, pretty humble beginnings. What does it mean to you and to your family for you to kind of finally reach that goal?
Oh my God. It's
Everything,
like,
I'm sure, right?
yeah, it's incredible. And it's not just like you said, it's not the title. It's just the journey. It's like having us like collectively like look back and say, wow, like my parents worked so hard to get here. My parents are like both immigrants. They worked their whole life to give us an opportunity. And then we both, my brother, the same, he also graduated, no debt, like has a great job now. It's like for us to turn around and say like, wow, like all the hard work and like the dream is actually like reached. It's like we've all, I think this past year now that we're both working, have like sat back and we're like, wow.
Yeah,
like,
they cashed that dream in. That really worked out. It's you know, my wife's kind of similar thing. And her you know, her mom's you know, a political refugee from El Salvador. Her dad's from Mexico. And, you know, it's just kind of like such a cool perspective to kind of see, you know, people who aren't jaded by, you know, the world. And they still say like, we can still do this and, you know, hopeful. And that's awesome.
Yeah. It's the spirit. Like, it's just your culture kind of like that you just bind down together, and it's like whatever comes your way, you handle it as a family and you figure it out. Like one person's down sometimes, another one's down sometimes, but like you pick each other back up, and there's always like, that's the one thing I think that has kept me going. I've always had my family, like my rock, like to go home and crash onto. It's like no matter what, like
your people,
my people,
your village, your you know,
my
your safety
circle.
net,
like it was always someone like there that was like consistent, like whether it was Chicago, like UIC EMS, like my parents back home, my brother, like there was always some like safe circle that I could like turn to, like when everything was crashing down or I felt like I couldn't keep going. There was always like that like comforting person that I know was able to kind of give me a hand when I was down too, whether they knew it or not, like whether you guys knew it or not. Sometimes I came to class and I was having the worst day, or like trying to study for the MCAT. Like I was just like dying going through it. And then I'd come here and I'd see the students like so full of energy and so ready to learn. And you all like so passionate about, you know, what you're doing. And I'm like, okay, reminded, like, it's, you know, there's reasons that I'm here and I can push through because it's all worth it.
And I think that's a good lesson of life though. You know, it's like, to understand that we're all going through stuff, and that you know, it's to have a little bit of empathy, extend a little bit of kindness, because you don't know what somebody's going through, and of course, people sometimes abuse that. You know, that being educators, we have people all the time who are, you know, faced with circumstance, and you know,
and who are we to say that they don't want to? They might just not want to share, right? And I think you just have to give them the benefit of the doubt.
Family emergency, nondescript.
Emergencies.
Well,
Amy, so you're living the dream, and I'm curious how you ended up in psychiatry.
So
you know, I'm sure it's always like assumed that someone who started in emergency medicine might just, you know, leave or you know, keep going in EMS. What were some formative experiences that pushed you in that direction?
I mean, I definitely always thought I would be in more of an acute, like EMS, like either the emergency department or maybe family medicine, like something more out on the front line kind of thing. But once I got into medical school, I did my family med rotations and I did my emergency department rotations. And I was just always drawn to the mental health crises. Like that was always my immediate like top of the line. I'm like, oh, like, yeah, like, let me pick up this patient. I want to take that, that case. Or, and particularly my family med rotation was here in Pilsen. It was actually at the Pilsen Family Med Clinic. So
on Ashland?
On Ashland, yeah, in the middle of the pandemic. So you can imagine there was high rates of depression coming through. And I was one of the few people who spoke Spanish, and I was a native speaker. They looked at me, and as soon as they came into the room, there was like a sigh of relief almost. And like so many patients, it was like first time ever expressing like feelings of suicide, feelings of depression, feelings of isolation, and being a student and kind of walking into that, and then turning around and telling my attending, hey, like I need like a referral to a psychiatrist, or like this patient needs mental health services, and then turn back to me and say, well, we have none in Spanish.
Yeah.
Like, well, we can put them on the wait list for 2 years.
Yeah.
Oh my God, 2 years. Who has that time?
It was 2 years at that time.
My wife saw so because we lived in Pilsen, and she saw a doctor there. I don't remember the doctor's name, but it was family medicine. And she was a Spanish speaker. First generation, kind of like my wife, born here, but parents weren't from here. And she, my wife went in there because of anxiety and depression.
Yeah.
And she, she was lucky that she was able to get, do you want therapy? We're going to prescribe you sertraline and, get started right away, instead of someone who has to wait with that unknown and that,
Yeah. And that is kind of what got me. It's like, okay, like we'll start them on something, hope it works. But there's not any like next line follow up.
I think long wait times are universal though. Is that kind of correct?
Yeah,
okay.
But
Specifically it's the Spanish speaking aspect of
That's
it that like,
layer.
knock, knock. Hey, Amy, you're needed here.
Yeah. That was literally my epiphany. I was like, oh my God, like I could do so much good if I went into this field. And I realized like, I imagine going to, a place like that, but not having someone who speaks your native language, and then having like a third interpreter in the room while you're trying to spill your guts.
Yeah. Well, particularly UIC.
Yeah.
I mean, that you look at probably the patient demographic at UIC, and you have to assume that maybe even a majority
65%?
It's 30-something percent.
Oh, 30%, okay.
Yeah. At least like across the board.
Okay.
So
And-
like in different specialties, it's different.
Yeah, I mean, that's just...
Yeah.
I'm curious how long it takes when you call 911 to get a Spanish translator.
It's a great question.
Yeah. Well, I mean, in the city of Chicago, it is becoming like a Latino-dominated field. A lot of, the newest paramedics are Latino, the newest firefighters are Latino. So like, I know like in where I work as a firefighter and paramedic, it's Latino or Polish. And, I speak enough Spanish to make my way through it. And we have a lot of Latinos that work in the fire department. Some of them don't speak Spanish, but some of them do. So I feel like Spanish speaking, we're able to do it, but Polish, no way. I mean, I don't understand any, and that's funny because I'm half Polish.
I was going to say, I'm like,
but 100% Mexican, baby. I was adopted. So adopted by mi gente. I think that's scary because you're scared about being sick.
Yes.
You're scared about what that means.
What if you don't even go in because you feel like no one can understand you?
Yeah.
Yeah. That's...
Well, I mean, even to get even further down the rabbit hole when it comes to like, public health in Latin American communities, like diabetes and high blood pressure. I mean, I can't tell you how many of my wife's family I've heard them say, and these are educated people who say like, I feel fine. I don't need to take my diabetes medication. I don't need to, and their dad died from kidney disease and a stroke, and it's just like, I don't need to do that. So I think it's like a generational cycle that is really tough to break.
You would think that death is like a wake up call. and you try to dig deeper.
Yeah.
Why did they die? You know,
Yeah.
if
They
it
got
wasn't
sick. Yeah.
sick from what, right? You start connecting the dots, and you hopefully trace it back to a point
Yeah.
like, oh, kidneys, oh, maybe diabetes, oh, maybe I should watch my diabetes.
In type 2 diabetes, like 100% of my wife's, and I'm, sorry, putting you on blast, Marlene, but like 100% of my wife's family on one side is diabetic, and these are people who, vary in their fitness, vary in their, general health. Besides that, it's a congenital thing. It's genetic. And the problem with type 2 diabetes, particularly compared to, type 1 diabetes, is you might be asymptomatic, or you think you're asymptomatic, you're a little sluggish, a little tired, but you might be asymptomatic until you have a stroke or until you have a heart attack. And they just I had a patient today who, and she wasn't, Latina, but I had a patient today who took her blood sugar. It was like 270. And I'm like, do you have diabetes? And she's like, no. I'm like, yeah, you do. And it's just like, because so many people, unless they're going to doctors, unless they're going to doctors regularly.
I don't. I haven't. I'm uninsured still. 3 years.
Not good, Vic. Not good. This is America, not Europe. They don't care about you.
Yeah.
Yeah.
Got hit by a bus.
Yeah. Yeah.
No, it is.
Hopefully
It's tough.
CTA pays you. But then maybe you'll break even with your healthcare bills. But yeah, that's a huge problem.
It is.
And
Yeah.
that's a point I like to hit all the time in the EMT class when I talk about like type 2 diabetes.
Blood pressure.
Well, and just people don't know about it. And I feel like almost like
It's
EMS,
so reactive rather than proactive, right?
Yeah.
well, in the emergency department, they'll say, "Hey, your blood sugar was high. You need to follow up with your PCP," and they don't.
They don't
And-
usually have a PCP.
Yeah.
That's the thing.
So I guess along the same vein, like, do you see recurring admissions? Like, and can that be? Is that frustrating for you if people don't put in the work to change?
Yeah.
Like, what else can you do for them?
Yeah, no, I mean, within psychiatry, it's a different, it's different. Typically, if we have patients that are coming back, UIC is pretty acute in their inpatient unit. So it's a lot of it's very severe psychosis and mood disorders. We do have a lot of substance use as well, or mood and substance-induced mood disorders or psychosis. But for the most part, you can't, in our field, you can't really always blame the patient. Usually it's psychosocial stressors that kind of go on and cause them to have to come back, or, they can't, they're just too ill to take their meds on their own. So someone else has to give them to them.
Yeah.
Sometimes they miss a dose and that automatically they get thrown into another episode. But as far as, and that's why I love my field, because I don't, for the most part, I don't get frustrated with my patients. My patients are so severely ill that I get frustrated with the system more so than them.
It's out of your control.
It's out of my control, and a lot of times it's out of their control.
Right.
A lot of times it is. It's their illnesses, at least in our hospital, are so severe that they really need 24-hour support. They need to be in long-term
Thanks, Reagan.
facilities.
So the framework is broken. Do you feel like you're coming from the perspective of reactive versus proactive, or even on a reactive basis? Do you feel
Can
like
you
you're
even be proactive sometimes?
Do you
that's
feel
the
like
problem.
are you
You can't.
tackling the root cause of these issues, or do you feel like you're just putting a Band-Aid on symptoms?
I feel like it's more so a Band-Aid. Unfortunately, a lot of mental illnesses, as far as psychotic illnesses, those are first break. So first break usually occurs sometime in college.
Yeah.
So there is no way of knowing about it unless, I guess there is a way to be proactive, and that would be families talking about their
family history.
And being aware. I was never aware of my own family, mental illnesses in my family, until I went into the field and actually recognized them myself and said, oh my God, talking to these individuals, hey, what.
And would you have
So-
recognized it had you not gone into psychiatry, just
No.
based on the clinical rotations that you did in med school?
I would have never known because a lot of them were well treated, well managed.
Yeah.
So it wasn't until like I was much older and recognized like subtle things and or like episodes would occur and then I would be involved obviously. So I had no idea because if it's well managed, people can like
Function.
Yeah, if they're
Yeah,
high
it's like-
functioning.
like anything else.
Like anything
Yeah.
else. Like diabetes, like everything else. Like there is a way to manage it well.
Are there certain conditions you feel more fulfilled treating or seeing?
I at this point, I feel like everything is kind of newer to me. I just finished my intern year, so I'm a second year now. So I feel like at UIC especially, I've gotten a full breadth of everything.
What does that mean? So are you doing like inpatient, outpatient? You still
Inpatient.
have like some aspect of emergency medicine.
Yeah, so we are all inpatient for the first 2 years,
Gotcha.
and then they start transitioning us to outpatient.
Oh,
so it's
okay.
very acute in the first 2 years.
Is that the way you would love to be it done if you were to do it again?
I think so. Yeah, I think that the high acuity up front is
Yeah. Okay.
They have to throw you into the fire basically.
See.
Well,
Yeah.
mental health, behavioral health is a huge thing in EMS. I mean, responding to behavioral crises is like something we do almost every shift. I feel like a lot of people, care is initiated on the acute end. Care is often initiated by EMS or police bringing somebody
Yeah.
in. And I feel that like as a paramedic, very unprepared. I mean, just to go through my mindset as a paramedic, arriving at like somebody exhibiting, that quote unquote psychotic break, exhibiting bizarre behavior, not acting normal. I feel like we almost have no tools or really education to really get a handle on this situation because I feel like we're ultimately painted as, or we feel like the bad guy because you'll have people having this issue and our job is solely to convince them to get on this ambulance and to get them to the hospital. Prior, we used to have police help us. Police would help us get the person in the ambulance through, sometimes through force. But you have someone, just to describe a situation, I have someone in a basement screaming, they're bloody, they're naked, what are we supposed to do?
Yeah.
And we had to utilize PD, but now police are saying, I can't help you. So it's just like,
Wait, why not?
because they won't. The police culture has changed. They say that, well, I mean, like in a situation, someone's bloody. Yeah.
Oh.
But like I had a patient a few months ago, this lady's like, they're taking pictures of me. They're saying that,
But like,
I'm a pedophile. I'm not a pedophile. They have pictures of me on Facebook.
This is the patient?
Yeah.
Isn't the bottom line safety though?
But police would not help. They would not help.
Yeah.
And she's like, I'm refusing to go. I'm not. And it's bizarre behavior, but police will not help.
Yeah.
So we're sitting there trying to convince them.
Yeah.
And then we're like, no, sorry, you can't. There's no follow-up. There's no mental health professional checking in with these patients because we just call med control and we're like, we're calling in a refusal. They're like, we're not granting you a refusal because it's not a refusal. It's that it's not safe for us or appropriate for us to strap somebody down to a cot without the help of PD.
That's so interesting. Yeah.
Because we're going to get charged with assault and battery.
I should have asked Chief when I saw her last, but like the fire department rolled out a mental health kind of professional to certain patients. And curious, like as to like what you know now, would you feel like what minimum level of mental health education is required to get dispatched to a potential mental health crisis?
Yeah.
Well, I mean, and even like bringing it to EMS, do you think EMS is capable in handling these situations.
It's just like, what would you add to the education?
Yeah.
Yeah, I think, I mean, this is such a huge issue too. As far as the education, I think that we could definitely add curriculum and topics that would be very relevant and very helpful, informative in approaching behavioral cases like that.
Where would you start? Would you start with specific conditions, or would you go through mental models or scenarios on how to build rapport in difficult situations?
I think as far as like the extreme cases, if you have a patient in psychosis, whether it's drug induced or any type in general, I think, like you mentioned, safety is always going to come first. So if there was anything that we added to the curriculum first, it would be like psychosis and how to manage an agitated patient for whatever reason, like any type of agitation, and working in the different differentials that could be caused by. But bottom line is, they're agitated, your safety is in danger. So how to safely either de-escalate and or evacuate. Like what is, like, I don't know the laws around that. Like you mentioned, you couldn't.
It used to be, what it used to happen is like police would come there, they would, they have a different authority than we have in fire and EMS. And they say, you're going to the hospital. And patients would often sit down and go to the hospital. Yeah. Or the cop would say, they wouldn't strong arm them, but they would escort them to the cot. They'd sit them on the cot, cuff them to the cot, and that worked out so well. I get the perception, and and that's something I always say to students in the line of safety. Yeah, like there is a issue. People take issue with police being dispatched to everything. They think that sometimes they are they fuel some sort of fire or flame. My opinion is that for me, and I've said this before, EMS is not my life. It is my job. Yeah. And I am not getting hurt on my job. No, it's not worth it.
You have a family.
I don't, and this might sound harsh or mean, but I don't care about the patient's feelings beyond my safety. So I understand they might feel uncomfortable, but my safety is more important than that. Yeah. And like you said, I have people at home depending on me. So I'm never not going to call police if I think that I need them. But what it used to be is like that case in that person in their basement. I mean, we gave them Benadryl, we gave them Versed, we sedated them, and then got them on the cot. Now their EMS is really trying to step away from that. Like we don't use the term excited delirium anymore.
Oh, wow, really?
You cannot use that term anymore.
Yeah,
there's a negative connotation to that?
There is, yeah. Yeah.
So it means excited and crazy. That's what it means. I mean,
so psychosis is that the word now, or
it's not? Well, it's not. No, it's agitated
agitated.
But I actually really try to use my wording around mental health. I don't say the word psych. I don't say we're going to a psych call. People say that all the time. I say behavioral emergency, mental health crisis.
Radio reports are outside of the ambulance, not in front of the patient.
Well, we brought a patient yesterday. Is this a psych or is it AMS? I'm like, I don't know. I don't believe it is a behavioral, mental health centered behavioral call. I think it is a more metabolic issue.
Right.
And they're like looking at me like, what are you talking about? Okay. But, and I think that it's like, through different lenses, healthcare is different things. Like I was saying, like back to the original discussion or the original thing I said, like with a mental health patient, what actually, in your opinion, is there anything more that we can achieve other than convincing someone who doesn't want to go to the hospital to go to the hospital?
That really is bottom line what you all can do in that situation. I mean, you mentioned giving them sedatives to help them calm down and prevent violent acts occurring, but Other than that, no. I'm aware of a document called a writ, so that you can. In that scenario, I think police are required to go and get the patient.
So like a certificate petition.
Yeah, and that's typically when we do have combative patients, how we admit patients involuntarily.
Yeah, and you guys initiate that.
Yeah.
And the problem is, like you were saying, like so many of these patients, they don't have any established care.
Yeah, and that is the issue.
My wife was telling me about a case about a mom trying to get mental health services for her undiagnosed schizophrenic son who been in and out in EDs for psychosis, but never got.
How is that possible?
People slip through the cracks. And I mean, mom begging for a cert petition and them not granting it because but we used to work on the private ambulances where we were moving people around like, commodity.
Hot potatoes,
and that's really what they were. They get paid when they would transport them to certain ambulances and, Medicare fraud and all those things. But, I think that, so with regards to like let's say a person with suicidal ideation, is there ever a line in which there shouldn't be transport? Because like it's so many times like we go to a residence and it's, he said, she said, they said they were going to hurt themselves. They said they were going to kill themselves. We talked to the patient, they say, no, I never said anything like that.
Right.
I would never say anything like that. What advice would you give like the paramedics or an EMTs responding to a situation like that? What would you say that should be done? And like, how would you justify that?
I mean, in my opinion, I would always say it's like, okay, like hear them out, like let them give you their story. But at the end of the day, I would recommend that, okay, like, I hear what you're telling me. The call was placed, so we'll take you to the emergency department. They'll do an evaluation and, we'll go from there. Like,
and just to go a little step further, because we don't really see what happens after we take them to the ED. So someone comes in for SI or a parent SI.
Yeah.
Who are they evaluated by in the ED? And when is the decision made whether or not this person, they need to be held, they need to do inpatient?
Yeah, so when they arrive with you all, they'll go through the triage, whatever. They get to the ED. An ED doc will evaluate them, take the full assessment. Why are you here? What's going on? They'll medically.
Are there any additional questions that they ask that we don't to determine that?
Nope. They'll pretty much do the standard workup. They'll get labs,
labs,
et cetera. EKG,
clear medical, right?
Clear them medically.
Okay.
Get a U-tox to see if anything's been going on. And then at that point, if that's all clear, then they call psych. They call the psychiatrist, comes down. I come down to the ED. I talk to the patient. I get the full history. Likely they'll tell me the same thing they told you. Or sometimes they do kind of after that point, like say like, I do need some support.
Yeah.
Like they'll open up a bit. If they don't, it's like, okay, I have to talk to other people. I have to get some collateral. So we do collateral calls. In the emergency department, we're allowed to call anybody that we have contact to regarding that patient to get more information.
So like family,
exactly,
friends.
Family, friends at that point.
But I don't think that's something that we have in the pre-hospital sense. What if someone at the bar has a disagreement? They're like, I'm claiming this person's suicidal, so I'm going to call the cops on them just to give them a hard time.
It has to happen.
And then the ambulance rolls up. They're like, I'm not suicidal.
Yeah.
And then who do you believe at that point?
Oh, I'm sure it happens. I'm sure it happens all the time. And at that point, I mean, you have to sit and talk to that patient. You can ask them, outright, like, is there anyone I could talk to? Like, is there anyone here that knows you that could vouch for that?
Yeah.
You could do that. But honestly, and if I was in that situation, I would err on the side of, I understand,
but there's nothing we can do.
This is my job.
Yeah. I wonder how many times like med control has received that phone call asking for a refusal.
There's no way on a recorded line that anybody is going to allow you to grant a refusal in that situation.
Yeah.
And I think I have had situations in which we had a patient, same thing. They claim, I remember there was this person, big guy, big as in could snap me in half big. He was sleeping. We woke him up. The cops were there everywhere because it's standard. They have police dispatch with us. And we wake him up and he's like, what is going on? His mom said that he threatened to kill himself and that he's been taking pain pills, which he were prescribed. It was unclear if he tried to overdose on them or he was planning to overdose on them. And the mom's like, never mind. But it's like, we're already there. There's nothing we can do. And I remember the one thing I said to him, I'd be like, there's the decision, you tried to be, well, you're always cordial. You're always polite.
Yeah.
But you kind of get to that point eventually where you tell somebody like, there's no decision to be made here. You have to come to the emergency department.
Yeah.
There's no option to say no. We're not having a discussion. We're just letting you know what's coming.
Yeah.
And, there's that common, we do this the easy way or the hard way. And sometimes you say like, we can let you walk down. We'll have you walk down, sit in the cot. But if it won't work out that way, we will force you to go to the emergency department one way or the other. And there have been situations where we brought those combative patients and then they're cleared by psychiatry. And I guess really, you can't solve that any earlier than that point.
Yeah.
I mean, that's the point. And it's like, once these things are in motion, they're in motion.
Yeah.
And I think, and I guess it's almost like one of these things where like, even though like these can be acute patients, like with a cardiac patient, you push a med and it changes the rhythm. But they don't have a medication that you can push to change someone's mood, right? I mean, to a certain degree.
Right.
I mean, or like with that immediately. So like, when someone's an inpatient, it's not like, okay, you're in diabetic ketoacidosis. We're going to give you some fluids. We're going to, get your blood sugar down. And once it's down, you're good. So I get like with these patients, it really is like, a combination of speaking to them, managing them with meds, kind of playing social worker as well, ensuring that they're going to have the easiest time when they get out.
Yeah.
So like back to the original question, what do you think someone would have to know and what could they do better than what's already being done with this kind of initiative that was mandated by the state, but no funds were given? Pretty much they told everybody, you need mental health providers. And, our community, it's the same thing. There's no difference. So do you think there is anything more that could be done by these professionals? And do you believe that what sort of training or qualifications should these people have? Should these people be physicians? Should they be nurses? Should they be, marriage and family counselors? What do you think?
Imagine having like social work under your belt as a pre-hospital provider.
Yeah.
But even if you did have that, what can you do differently?
It's
a better perspective.
It's knowing resources.
Yeah.
Yeah.
Yeah. So to helping patients, the end user, connect the dots.
Yeah. But in EMS, do we have the opportunity or the time to set them up with these services like social workers
but oftentimes,
have?
like even in like a 5-10 minute interaction, like we want to help, but don't even know what to
do.
And I think that goes back to like, if you're going to be the best paramedic or EMT you can be, you should be familiar with those resources.
Yeah.
You should be able to, and I think that sometimes people just want to take the patient, get them to the hospital, go on the next one, but actually taking the time to speak with them, kind of really have that empathy. Even something as simple as like, your blood sugar's low all the time. We've been here 3 times this week. Yeah. You need to call your doctor. You're taking too much insulin. You're not eating enough. Like, you're going to die. Just having that tough conversation instead of like, okay, going to push the D10, blood sugar's back up, sign this refusal. I'm done.
Yeah.
So what would you think about that, Amy? Do you think that any more could be done?
I think, like we mentioned before, I think there's a lot that we could do proactively instead of reactively. So, I mean, we need more providers, whether they are nurses, whether they are counselors.
Like, so
whether
are
they
when you say providers, are these people that are amongst the streets that are dispatched, or are these mental health centers? Because if we had centers, then we are thinking that individuals will take the time to go to these centers proactively.
right?
Or you have a whole different field of emergency response.
Yeah.
Where
Kind of like community
and I think
paramedicine.
that's like even separate EMS out of it. Just kind of like you were saying, like in the ED, and we're like, EMS is an extension of ED. ED just clears medically. What if you have first responders who are, purely, behavioral health.
Yeah.
And have a whole new field. But the problem with that is like, well, are these already established providers? How are you going to pay for them? How are you going to make it worth their while? Do these people want to go in these situations?
But that's then the safety
Right.
issue.
Yeah.
And that's why you just keep on going in this circle. Like, how do we fix this?
Yeah.
And,
And I think we're on the education side, and every provider has an opportunity to educate.
Right.
But on the education side, it's like it's having these discussions of like what additionally can be implemented to create new providers with a more well-rounded sense of mental health.
Yeah. Yeah. And I think, the pandemic, I think, has just kind of highlighted that need and highlighted the importance of mental health and mental health awareness. So I think we are on that path, but now we're at that stage. It's like, okay, we know this is a problem. We acknowledge this is a problem. What do we do about it? And how do we, first of all, find the funding for it? It's just
the number of ways to tackle this issue of mental health is like infinite.
Yeah.
Is it through prison reform because it's affecting the family unit, right? And if we can fix the family unit, wouldn't that create or like solve a lot of the family like unit issues? And as we saw in the pandemic, this social isolation, not being able to be around other individuals, just escalates mental health issues.
Yeah.
So there's a million ways to
I think almost answering, finding that solution is like finding out what's wrong with humanity. It's
find more
How do you
friends
fix-
because
Yeah.
this is not. Mental health has always existed, but it is more an issue now. At least it is more visibly an issue now than it was any time before. And you do see the United States in particular struggles with this versus other places in the world. And, why is that? And I think to your point, I think it is kind of there is this, the lack of your own community, like your family, to bring it back to family, to being alone.
Yeah.
Yep.
How many of your patients
Loneliness
just
is
don't have anyone to talk to listen to? Right?
You look at EMS and at like emergency services, people with chronic health issues, people who have families that they depend on, statistically are less likely to call 911, because they have someone keeping them accountable for their illness. But you also have somebody who'll be more proactive and advocate on their behalf.
Yeah.
Like if I was feeling sick, I wouldn't call 911. My wife would drive me to the hospital, right? But some people don't have that option. And it's why is that here? And
I think it's the culture.
it is culture.
It's very individualistic here. It's everyone, even if you have a strong family like cohort when you're little and growing up, like the thought process is you grow up, you go away to college, and then you start your own family, and then you're in a different state because you went to a different college. And so, the society is just set up to be individualistic, isolated on your own. Whereas in other countries, your family unit just grows. It just keeps growing. And you're expected to...
You marry someone you knew your whole life.
Yeah.
It's just...
Yeah, I think social media and the
Oh, social media is trash.
Yeah.
Follow us on Instagram.
I have a TikTok. Yeah. No, it's
To play devil's advocate, this increased awareness and visibility of mental health. I feel like, to play devil's advocate, I feel like some people use mental health as an excuse or a crutch as to why they're currently experiencing what they're experiencing. And I'm not saying that's not the truth, but at what point, like how much accountability should someone take for themselves?
Mm-hmm. Yeah, I mean,
is anxiety something we should be treating, or is anxiety an emotion that,
is a symptom of a root cause?
Yeah. I mean, there are healthy amounts of anxiety.
Yeah.
It's a normal emotion that we all possess. It's when it becomes detrimental to your like social function, your life functioning.
Right.
But if you've done your due diligence and you've gotten, involved or like therapy or talked to your provider, even your general, practitioner, your health provider about it. I have anxiety. What can I do? You've tried those tactics. You've done different things and it's not working at that point.
Right.
I mean, there's something wrong there, like fundamentally, or there's an actual like generalized anxiety disorder or social anxiety disorder. But yeah, to say I have anxiety and therefore I'm not doing anything about it, and
like is medication commonly just prescribed and used, but without thinking that it's just a Band-Aid?
I think any time that I've ever, at least thus far, like seen when.
Like, would you hesitate? Would you hesitate to make like just write a script for anti-anxiety medications?
Right. We always counsel patients, and we talk about the fact that the medication is not going to make the issue or the trigger or the kind of life event any easier or go away. It's more so just an aid in allowing you to calm down enough to process that and to keep moving forward.
Then do you feel like you have, or even the desire to want to open that can of worms and go down that rabbit hole to identify the root causes? Because oftentimes pre-med students have this romantic view of wanting to spend meaningful time with patients and then are met with all these metrics that they have to meet.
Right.
A certain number of patients you have to see, and that reduces the meaningful time you have with each patient. And so in psychiatry, if you want to get down to the root cause, do you feel like, one, you have the desire to do that, and two, do you have the time to do that?
Yeah, I mean, definitely the desire, the time is the difficult part. I mean, most of the time, as far as inpatient, the anxiety is the least of our worries usually. Usually it's more severe, more acute. It's the depression, it's the suicidality, it's the psychosis, it's something else. And then once they're inpatient, like they will let us know that they have anxiety as well. And these are the reasons. We do talk to them about it. We see them on a daily basis, and we'll not necessarily explore if it's traumatic or anything like that. We don't open that up, but we will talk about like life stressors, anything that's going on that might be the cause of their anxiety or exacerbating it. And there are plenty of really useful medications that you can take that do work and that do make the anxiety a lot more tolerable. However, is that the only thing? No. We would 100% talk about, okay, these are the different tools that can be in your toolbox. Like medication is not the first thing that we want to reach for.
Right.
We have yoga mats for our patients that, they do, like
for beds instead of beds.
Some of them do use them instead of their beds because of other reasons.
That'll be the day you walk down the hall of an inpatient unit and everyone is
doing downward dog.
It's like,
No, it's pretty cool. They have a lot of group therapies like while they are inpatient because medication doesn't solve everything.
Well, and it's also, being in therapy myself, I've had my therapist say like something like anger is a secondary emotion. It's a secondary reaction. And I think like with anxiety, like it could be a secondary reaction. There's a stimulus making you anxious, or is it anxiety itself? What is it? So I think that's kind of a unique position or thought.
Anxiety is the number one most prevalent like mental health diagnosis.
So without taking too much of your time, like what's next for you? Do you want to go deeper down the rabbit hole with the serving the Latino community, or what's next for Dr. Amy?
Yeah, I'm actually super interested in child and adolescent psych. So next step is going to be doing a fellowship.
What's the youngest patient you've seen?
I've seen outpatients. I think he was like 5 years old.
5?
Yeah.
What were the what was the complaints?
It was like behavioral issues, like dysregulation. Ultimately, like it ended up being hyperactive. ADHD. Yeah.
Gotcha.
Yeah.
Speaking of adolescents, two adolescents just walked in the room.
Cuties.
Yeah.
Right, Junior.
Hey,
Hi.
hey, baby. So, is there anything else you want to say or plug or
manifest?
Yeah, I mean, I just got engaged.
Yeah,
Awesome.
yeah.
Awesome.
Wow.
Here's one question that could be like a whole podcast series. What is your view on psychedelics in the use? As I wear a Grateful Dead t-shirt,
Are you seeing more prevalence or like talk about the use of like therapeutic?
Yeah, there
psychedelics?
is. I work at the VA also, like the hospital and the VA. So the VA has recently started a new research program around psychedelics. So like basically microdosing.
Yeah.
And how that affects, I think specifically PTSD.
Yeah.
What medicine?
It's mushrooms.
Psilocybin.
okay.
Yeah.
Okay.
Exactly.
Wow.
Yeah.
Yeah.
So, I mean, if it works, I have no real education around it because it's so new.
Yeah.
So I am very intrigued, and if it's effective, it.
Yeah. What if you were the first to set up a psychedelic
Ayahuasca ceremony?
Little clinic in Pilsen?
Victor and I will sign up.
I'll back you. I'll back you, Amy.
But I think it's kind of back to your point that or just the point of healthcare is evidence based. So, and I think that the problem with psychedelics is that they were automatically written off by people who weren't healthcare providers. They were law enforcement. So I think it's psychiatry, it's kind of cool because it is there is so much more to learn about and know that is unknown. Where, when you look at emergency medicine, like, of course it's going to develop and evolve, but I think that the way we think of mental health is
rapidly evolving.
Yeah, exactly.
Yeah, it's new, it's different. I mean, the medications that we use are relatively so new, but there's already new coming out that we're constantly learning about, and so. New research around psychedelics. And so.
Do you ever feel pressure from pharmaceuticals to push certain medications?
Like lithium?
So I definitely through my, what is it called? The, Facebook, professional Facebook. What is it? I'm blanking on the name.
LinkedIn.
I'm never on LinkedIn because I don't need it because I've been in school for 20 years. But I have a LinkedIn account and I constantly do get messages from pharmaceutical, pharmacy companies like, hey, we'd love to talk to your you and your cohort. We'd love to pitch this and that. And we are very well protected through our residency program, so we don't experience it. But I imagine as an outpatient or an attending down the line, it's got to be rampant.
It puts people in a lot of ethical issues. Because I remember Victor and I, when we worked at ATI for years, and we would often transport patients from a lot of these, behavioral health nursing homes to Methodist, which is no longer Methodist anymore. But there was a big issue where all these patients were patients of one singular doctor who was prescribing medications that was having all these extrapyramidal symptoms.
That's a new one.
Yeah, and cause seizure disorders, dystonia, all these issues people were having, and he went to prison. So
I forgot about that.
No way.
Yeah, he lost his license.
Wow.
And he was a big shot at this hospital, and
Wow.
he was an older guy, but he was getting. They bought him a house in Florida. They bought him a boat. So I mean,
That's awful.
And the problem is, it's much easier to exploit somebody who has mental health issues. And just we're helping them. We're helping them.
Yeah.
So,
That is, I think, one of the most frustrating parts in my job is the level of vulnerability that our patients have, and seeing like how sometimes they are so like taken advantage of. It's so sad. Yeah. No, it's.
Well, I think that's why a lot of us get into it, is because we become help for the helpless and a voice for the voiceless. So,
yeah, exactly.
Patients are lucky to have you.
Advocates.
Advocates.
Anything else, Amy, before we hop off?
I really appreciate you guys having
Thanks
me
for spending
here.
the time.
Thanks for all your participation in our programs throughout the year.
Couldn't be prouder of you.
Thank you guys. No, you guys are literally a second family to me. I can't express it enough. I always told like my friends, and I'm like, oh yeah, I'm like going, like I get to go to work and like see my EMS family, and like it's. I've literally seen you both grow and become your own families.
Right. Yeah.
It's been a pleasure, and it's been such a privilege.
Decade.
It's been a decade. It's been over 10 years. It has. Yeah. So thank you.
All right. Thank you, Amy.
Thanks, everyone. Till next time. Bye.
That was a good one.
Keep going.
What do you want to say to the world?
Nothing.
Do you want to say anything to the world?
No. Nothing.
Oh God.
We're gonna have the kiddos on one day.
Yeah, they should do their
Just
own.
by themselves.